Well, thank you everyone for staying this late on Saturday. I'm from Chile, so I'll try my best so you can understand me. I'd like to thank my colleagues, Hector Molina and Francisco Pacheco, who are here with me today. And, well, let's start. I've got nothing to disclose. Well, gastric cancer has the fifth highest incidence and mortality rate worldwide, despite a decline we've seen in the last decade. We all know that in Korea and Japan and other countries with very high incidence, they make early diagnosis, but this is not true for the West, where over 50% of patients are diagnosed late in the onset of the disease. Well, and this is the case of Chile. Chile is a rather long country with 9 million people, nearly 20 million people. And in Chile, it is the fourth most frequent cancer site and the second cause of death for malignant tumors. In comparison, the United States, the incidence in the States is 7 over 100,000 people, with a mortality rate of 3 or 4 over 100,000 people. And in Chile, the incidence is 25 per 100,000 people. So it has a very high incidence. So we all know histologic subtype is important in diagnosis, in recurrence patterns, and response to chemotherapy, to neoadjuvant chemotherapy. And there exist different classifications for histologic subtypes, like Loren classification, the Japanese classification of gastric cancer, and the World Health Organization classification. But diffuse type gastric cancer is an aggressive form of gastric cancer. It is distinguished by the presence of poorly cohesive cells and or cygnus cells that are also present in mixed type gastric cancer. So for our study, we consider both diffuse type and mixed type. So it has been suggested that a total gastrectomy with D2 lymphadenectomy is the preferred surgical approach in diffuse type gastric cancer. This is more an expert recommendation. There has never been like very strong evidence for this. And also several studies have reported worse survival outcomes in mixed type gastric cancer. So with all of this in mind, the aim of our study was to determine the overall survival and disease-free survival in patients undergoing total versus subtotal gastrectomy for diffuse type gastric cancer. So this is a retrospective study. We got 553 patients that underwent gastrectomy with curative intent between the years 2009 and 2020. 423 of them were excluded because they had intestinal type gastric cancer or a proximal location. So we got 130 patients with diffuse or mixed type gastric cancer, and we divided them into groups depending on the type of surgery they underwent. So the surgical technique was pretty standard. All these surgeries were done via, they were open surgery, a laparotomy. D2 lymphadenectomy was the standard oncologic for all of these gastrectomies. And the esophageal anastomosis was done with a circular CDH 25 stapler and reinforced. And the JJ was manual with a absorbable suture, and the mesenteric bridge was closed. So 130 patients underwent gastrectomy, 68 patients subtotal gastrectomy, and 62 patients total gastrectomy. All patients had tumor-free margins. The median number of resected lymph nodes was 26. The 90-day postoperative mortality rate was 1.5%, one patient in each of the groups. And the pathological staging was 54% stage 3 gastric cancer. Most of the patients underwent adjuvant therapy, and at that time, they received like McDonald's strategy with radiochemotherapy. So this table is a big table, but I just want you to see that both groups were pretty much the same, except that in the total gastrectomy group, the tumor was more likely to be located in the lower body than in the antrum. So the median follow-up was of 55 months. The overall survival in the subtotal gastrectomy group was more than 55 months because the median was not reached. And the overall survival in the total gastrectomy group was 44 months. And as you can see in this graph, this difference was not statistically significant. In terms of recurrence, after this median follow-up of 55 months, the 5-year estimated disease-free survival was of 65%. Again, the median was not reached. And the recurrence rate was of 34%. 44 patients out of the 130 patients had a recurrence. And most of them were peritoneal carcinomatosis, more than distant lymph nodes. And again, there was no difference between the technique used to treat these patients. So we then went forward to look for some prognostic factors in a union multivariate analysis. And we could see that only the lymph node, the age and the presence of lymph node metastases were statistically significant, were really related to a worse prognosis. So then we graphed these results, as you can see there. Having a stage PN3 has worse survival, we'll know this, but this was the only difference. So, as previously suggested in several retrospective studies, mixed-type carcinoma has at least an equal prognosis than diffuse-type gastric cancer. Some recent studies even say that it has a worse prognosis. And we can say that as long as an oncologic surgery is performed with negative margins and adequate lymph node harvest, the type of surgery is really not associated with a worse prognosis. The importance of the depth of invasion also seems to be strictly related to the probability of lymph node metastasis. And the size and margin is not a determinant factor as long as the latter is negative. So, a subtotal gastrectomy can be safely performed in patients with distal diffuse type and mixed type carcinoma. A D2 lymphadenectomy is crucial for adequate cancer staging, as the number of compromised lymph nodes is directly linked to survival. Very long-term outcomes are yet to be unveiled. For example, we don't know if we follow up these patients like in 15 or 20 years in the future, maybe they can develop a new primary in the remnant stomach. Well, this is one of the largest single-center studies in this specific topic, but a prospective analysis is required to definitely establish these results. Thank you very much.